Hello, just bear with me one moment while I pull up the PowerPoint. Okay, hi everyone. I'm Elizabeth Bloemen. I'm a fourth-year medical student that works with the Division of Geriatrics on this topic of elder abuse and neglect. So for this video session and then when we meet, there's two main objectives, mostly just to give you a little bit of an introduction into elder abuse and then what happens when you do detect or identify elder abuse, including the mandatory reporting requirements, but also thinking about the ethical, legal, and medical implications of what's been discovered. So for this recording, we'll just go briefly over the epidemiology of this phenomenon, a little bit on mandatory reporting and screening, and then what you should look for as a clinician. And then we'll wrap up with some resources that you can think about utilizing for these cases. And then when we meet, we'll have a few cases of elder abuse to talk about. And if you have any questions, please feel free to save those and we can talk more about those then. So I just wanted to start with a brief definition of elder abuse. So this is the CDC definition, which I like. And what I really want to highlight here is what makes elder abuse different than a stranger assault or other just bad things that happen to old people, is this expectation of trust. So to be considered elder abuse, an incident needs to happen within a relationship that would be trusting. So a family member, a close friend, a professional caregiver, etc. And this can include things that would constitute physical abuse, sexual abuse, neglect, verbal or psychological abuse, or financial exploitation. And really one of the core pieces to this phenomenon is that most victims suffer from multiple types of abuse by the time that it's identified. So every once in a while we see a case of just financial exploitation, but much more commonly, particularly when you see physical, sexual abuse or neglect, there's components of psychological abuse and financial exploitation going on at the same time. So being aware of how these interact and that if you find one, looking for others is a key thing to know as a clinician. And then I just want to touch briefly on this topic of self-neglect. So self-neglect is kind of a cousin field to elder abuse, and mostly because when you first see a patient, this is the two things on your differential perhaps. Is this an abusive situation, or is this an older adult where things just aren't going well and there's not necessarily anyone to blame, there's no malintention, and often there's just no one involved at all. So what often happens with self-neglect, and what I like to think about it is, you have an older adult sitting in front of you and things aren't going well in your definition of what should be going on. So I think it's important to remember that this is a very paternalistic kind of myriad of issues that can come into play, and you need to be aware of the urge to be paternalistic in these situations, because what we really need to figure out is this a choice that people are making? Is this a lack of resources? Or are there some cognitive or functional decline or mental health issues that are inhibiting them getting the best care or the care that they need or the food that they need, hygienic needs, etc. So what we often see is an urge to get them care, get them things that they may not want. And you really have to balance the patient's right to self-determination. And one of those is the right to risk and to make choices that we would see as not necessarily ideal. And so what this often comes down to as providers is looking at capacity. So does the patient have the capacity to make this choice? Is this a choice that they're freely making, or is this the result of a lack of resources, a lack of insight, or some mental health issues that we can help support them with and make things a little bit better for them? So this is a very murky area, but it's very interesting to talk about. And so I'm happy to talk about it with you all when we meet if you have further questions. In terms of the epidemiology of this phenomenon, so we're going to go back just to elder abuse now for the rest of the presentation. So I think most people don't think elder abuse happens all that frequently, but it's very common. So when we do telephone surveys with older adults, the number that we get is about 10% of older adults experience elder abuse or neglect each year. And that is a telephone survey. So we're only getting people who have access to a telephone, who have access to typically a landline, who are cognitively intact, living in the community, are cognitively intact enough to participate, living in the community, and then also people who are maybe not right with their abuser because they're not going to report. So if you think about the margin of those people, that's probably a pretty small piece of actually who's being maltreated in a year, but that's still a big number. And then when we ask those same people, how many of you had your cases reported to APS or law enforcement? Only 1 in 24 reported that their case was reported. So when we are looking as professionals and identifying cases, that is a number to think about, is that we're really only seeing the very tip of the iceberg in this situation. And the way I like to think about these numbers is really we're identifying the tip, but if you're thinking about it in terms of your clinical day, so if you're on an inpatient service and you have 10 patients over age 65, at least one of them is likely to have experienced some form of mistreatment in the last year, and similar to your outpatient setting if you're in clinic. So I think that really drives it home that maybe this phenomenon is actually something that we should be keeping an eye out for. And the other reason that clinicians should be particularly concerned about this phenomenon is because we know that elder abuse, in addition to having a lot of social and legal ramifications, has significant health outcomes as well. So the increased risk of mortality, the odds ratio there is about 3. So 3 times greater risk of dying in the year after abuse is found. That includes verbal and financial abuse. That's not just limited to physical abuse or neglect, which I think would more naturally be considered part of that. Partly because of the way our interventions are structured, institutionalization increases significantly if a patient is identified as being an abuse victim. And similarly, there's a number of physical and mental health sequelae of this victimization, including depression. So this really is a health issue in addition to a social, legal, and public health issue. So what's the scope of the problem in Colorado? So if you're looking at Adult Protective Service data that was available at least a couple of months ago when I pulled this, we see about 20,000 reports to Adult Protective Services each year. About 9,000 of them they actually open cases on. APS has a very strict mandate of who they can serve and who they can help, and they have a different definition of vulnerability. So I think that number is probably closer to the 20,000 than the 9,000, but that's kind of the scope of what they do. Interestingly, if you look at child abuse, those numbers are about the same in Colorado. So if you're thinking about these problems similarly, they're pretty equal in terms of numbers, at least. So then in mandatory reporting, so if you noticed on the last slide, there was an uptick in reports, particularly between 2013 and 2014. And that's because, I apologize, that's when mandatory reporting was implemented in the state of Colorado. And our law is different than a lot of laws. So there are mandatory reporting statutes in 49 of the 50 states in the US. New York State is still the only state that does not require mandatory reporting of elder abuse. And if you guys want to talk about mandatory reporting, please let me know, because it's a actually fascinating topic. But our state was the last one to pass it, and our bill looks pretty different than other bills. So we have an age-based cutoff, which many states have. So anyone over age 70 is considered a vulnerable elder per our statute and subject to the mandatory reporting laws. And this requires health professionals, social workers, many people in helping professions to report abuse if they are concerned about an older adult. And that could be abuse, neglect, or financial exploitation. Interestingly, the way our law works is that you have to report to law enforcement within 24 hours, not Adult Protective Services. So if you've practiced in other places before or plan to practice in other places, it's important to know which agency to report to. In the state of Colorado, you're required to report to law enforcement. Interestingly, clergy and financial personnel are also included as mandatory reporters in our state, and we do get a fair amount of cases from them. So it's kind of a just fun fact. And then if you're sitting in clinic or you're in your office and you're working with a patient who's under age 70 but could be considered at risk for other reasons, maybe they have an earlier onset dementia, mental health issues, severe physical impairment, they could be considered an at-risk adult if they're 18 to 69. And then we are mandatory reporters as well for that population. So just transitioning a little bit to screening, if you're looking for people in your office. So the U.S. Preventative Services Task Force does not recommend screening, universal screening for elder abuse, nor do most of the professionals working in this field, quite frankly. In the AGS, Special Interest Group on Aging, on Elder Abuse, I apologize, we did not recommend that they change this recommendation at our last meeting. And part of that is we don't have a good screener, and part of that is we don't have good interventions if we were to screen. So we do not recommend it at this point. If you have questions on this, please let me know. On the right side of the screen is arguably the best screen that we have so far. It's the Elder Abuse Suspicion Index, and it's really for clinicians to gauge whether or not they should be concerned about abuse. I don't like using it as a screen. What I like using it for is the language helps me ask about abuse in a patient where I'm already concerned. So if you are already concerned that something's going wrong with your patient, I do like the language and the wording here, so feel free to use it for that. So just a little bit about the phenomenon. So who should you be looking for coming across your door as potential victims of elder abuse? So let's just start with the perpetrators because they need to be exposed to them to be victimized. So I think what most people think about as perpetrators of elder abuse are professional caregivers. So home health aides, nursing home workers, etc. This is a less common proportion of the phenomenon, but is certainly part of elder abuse and is a problem. And what is important to know is that there is a disincentive for nursing homes to report abuse. So if a nursing home has a case of substantiated elder abuse, they lose funding through Medicaid and Medicare. And I like to bring this up because this is also a nice example of a good policy gone bad. So the policy makes sense if you're Medicaid and Medicare. If you're paying a facility to take care of people and they're actually abusing them, they should not get paid the same. However, what has happened is nursing homes now just fire that employee, don't file a report, and the employee is then able to go on to another facility. And this is where we have seen serial sexual assaults by caseworkers is mostly in these situations. So that is a concern. This is trying to be addressed on the federal level, and there are people working on this, but that's part of the phenomenon. So the biggest proportion of people that are actually perpetrating elder abuse are family members. So even in the nursing facility, we see family members come in and victimize their loved ones. But in the community, it's definitely mostly adult children and then significant others, with then other family members that have a close relationship with them, also representing some cases of elder abuse. So this could also be a close neighbor, a close friend, someone like that. But that's the vast majority of cases. So in terms of the victim, what puts someone at risk for being a victim of elder abuse? Social isolation is the biggest one that we know of. Just not having a lot of contact outside of the home, being dependent on one single person, those sorts of things. Having functional dependence and cognitive impairment are, of course, big risk factors for abuse, both because they increase caregiver stress, but also because it increases your time and your needs from a single person. And so you just have a greater amount of exposure to potentially a violent person. And it makes you less likely to get help or be able to report when things are going poorly. So those are our biggest risk factors there. And then poor mental health and substance abuse on the part of the victim is also recently being recognized as more and more important. These are people who tend to not be believed, not have access to resources, not have a lot of social capital. So that's also a big risk factor for being a victim. Similarly, as many types of family violence, unfortunately, having a history of family violence puts you at greater risk for family violence. So this is something we see in child abuse, domestic violence, sexual assault, and elder abuse, but is a significant portion. And the risk factors for perpetrators are not dissimilar. So having mental illness, having substance abuse problems, very, very common among our perpetrators. Being dependent on the victim is something that has more recently in the past decade or so been identified as being a really big risk factor. So being dependent on that victim for financial support, caregiving support, emotional support puts you at risk. Having a previous history of family violence yourself, again, as with child abuse perpetration, domestic violence perpetration, is a risk factor. And then caregiver stress theory kind of went out of vogue in the 90s, has had some resurgence. I think that all of us who work in the field know that this is part of the problem, but not all of the problem, but certainly contributes to elder abuse. So what should you look for if you have a patient standing in front of you? So in terms of the medical history, things that I think would raise anyone's red flags: unexplained injuries, frequent visits, delay in seeking care, all of those are very similar and should raise your concern for abuse for anyone coming to you. Things that are somewhat unique: doctor hopping or doctor shopping, where patients are going from different providers to get care. That could indicate that maybe they are trying to hide something or not get care from the same place. If a caregiver interrupts or answers consistently, and after you explicitly ask to speak to a patient alone, that would be concerning. A caregiver just talking on behalf of the patient, not that concerning. That happens every day in all of our clinics. It's the point where they won't let you talk to the patient alone. That's when the red flag should be raised. Similarly, missing medications and appointments, that you really need to suss out and think about. Is this because there's a lack of access, there's a lack of healthcare literacy, there's a lack of resources, or is there's something else going on? So I don't think that I would necessarily jump to abuse in those situations, but something to keep on the differential. In terms of questions that you should just maybe think about asking if you're concerned. So the main one I like to ask of is, who do you live with and how is that going? So aging precipitates a lot of changes. Often it precipitates a lot of moves, moving in with people or moving into other situations. So asking how that's going is never a bad question. And just that represents a time of stress for a lot of families. So asking about that, if you can ask about finances or substance abuse, great. But I think getting that will start to really get at how things are going at home. And then the other piece, usually ADL and IADL assessment, is in the social history, so that's why I put it here. But it's incredibly important for elder abuse evaluation. So unlike a 6-month-old, when we're talking about child abuse, pretty much 6-month-olds do about the same thing. 83-year-olds are incredibly different. So I've had 83-year-olds who are still mountain biking and running and doing all that versus completely bedbound, completely cognitively impaired 83-year-olds. So when I'm evaluating an injury or something going on for those two patients, my evaluation is going to be completely dependent on their functional status and their health. So understanding that and documenting that thoroughly is really important for these cases. For physical abuse signs, so we do not have the data that child abuse has in terms of injuries and what should be concerning. So some of these things are founded in pretty good research and some of them are more expert opinion. Atypical bruising is one that is kind of a mix of both. So locations that just aren't typical to get a bruise with a fall, the medial aspect of the upper arm, the upper back is relatively uncommon to bruise when you fall. The mastoid process is something that I always like to look at, and for the audiologists in the audience, you guys can get access to the mastoid process pretty easily, so looking there for bruising. That's, again, just not a place that you usually hit when you fall. It's not a slam dunk. You can certainly whack the side of your head, but it is pretty common with like a punch to the head when someone turns away or has other trauma to the head, so something to look for, especially in our little ladies with the nice perms that have their mastoids lovely covered. Patterned injuries, as with any abuse cases, are concerned things like belt buckles, cigarette burns, those handprints, grab marks, those things. Burns, similarly, like a submersion burn around the buttocks or a cigarette burn. There are a few fracture types that have been well established within the domestic violence literature, like an isolated zygoma fracture or an isolated ulnar fracture, but otherwise there's no specific elder abuse fractures yet. And then intraoral soft tissue injury is just something to keep an eye out for. That could be the result of force feeding or sexual abuse, so something just to look out for. In terms of sexual abuse, the physical exam findings are kind of hard to do unless you have the patient in a gown. But I look for bruising on the inner thighs, bite marks, particularly on the breast, Any new vaginal or urethral bleeding, penile bleeding needs to be evaluated regardless of your concern for sexual abuse. That needs to be addressed, but could be concerning. And new STDs, again, could be concerning or could be the result of completely consensual intercourse. So more follow-up questions need to be asked. And then neglect is one where you really need to look at the constellation of the patient and the family in front of you. So if my patient has one of these things, maybe I'm less concerned. If they have all of them, I'm incredibly concerned. So these are just things to look out for, but again, look at it in the constellation of the patient, not just, oh, they're cachexic, there must be some neglect going on. In terms of labs, I typically recommend getting these few labs here. So we usually get just a CMP, which can give you nutritional status, hydration status, CBC to look for infection, an INR and a PT is really to help with the bruising evaluation. If they have an INR of 5, that's going to really change my evaluation of their bruising pattern versus if it's normal. And then I often recommend getting a U-Tox because often substance abuse is involved in these cases. And so what you want to look for are things that shouldn't be there. Is this older adult being exposed to things that like methamphetamine or marijuana or other things that they're not necessarily wanting to participate in? But then also looking for things that should be there. If they're on scheduled opioids and they have no opioids in their system, that's concerning. If they're on scheduled benzos and there's no benzos in their system, hopefully they're not on scheduled benzos as a future geriatrician. But if they are, you want to look for that because medication divergence is often found in cases of elder abuse. So you want to make sure that that's not what's happening. Checking a PDMP could also be helpful for this evaluation. So now you have a patient, you're concerned, what the heck do you do? So if you're on the inpatient setting, we recommend calling a geriatrics consult or recommending to your team to call a geriatrics consult. We can help facilitate some of these things. In terms of who you're going to call externally, so you're going to call law enforcement because you're mandated to. But I also recommend always calling Adult Protective Services for the county that the patient's from. So Adult Protective Services and law enforcement are kind of the two arms of the community response for this. Adult Protective Services will work to increase the supports and the services available to that patient and that family and try to keep them at the home, in the home and respond in that way. Law enforcement can have, they're looking more for community safety, but they also can have things like orders of protection and other interventions that can be helpful, mandated drug treatment, mandated mental health treatment, things like that. So I encourage you as providers to not do necessarily what we're trained to do, which is not to wholeheartedly engage with protective services and law enforcement, but look at them as partners in protecting and improving the health and well-being of your patient. They can do things that we just can't do as physicians, and similarly, we can add things to their investigation and their response that they can't do as law enforcement or APS. So I encourage you that if you do need to interact with these people, look at them as partners and advocate for your patient and do that by engaging with them. The other people that you can think about working with are family and friends who are non-abusing. So often there are other people out there who care about this patient. And so engaging with them, seeing what they think about all of this, and then also providing them with support. This can be really traumatizing, particularly because these cases are most often intrafamilial. So making sure that they have the support that they need and that they're safe as well is important. If the patient has a primary care provider, engaging them. If they don't have a primary care provider, making sure they have a good primary care provider that they can follow up with is really important. And then similarly, mental health is really important for these cases. Being victimized, particularly by someone you love, is really traumatizing. And making sure that patients, even if they have cognitive impairment, have access to trained mental health is really important. So that's kind of my elder abuse in a nutshell. If you want to learn more about this, there's tons of resources out here. There's a good review article in the New England Journal. These websites are also pretty helpful. I like the National Center on Elder Abuse more for my patients, families, community members rather than professionals. The New York City Elder Abuse Center has some really good blogs geared towards healthcare providers, and the National Department of Justice also has some good resources. And if you're looking for any resources in particular within these topic areas, please just let me know. So my email is there at the top. And then Dr. Church is also really engaged with these cases and this issue, so you can also feel free to reach out to her. Okay, so I really appreciate you all tuning in for this, and I look forward to our discussion on Thursday. And if you have any questions, please just let me know. Thank you.